Hi everyone, and welcome to Henry Schein's webinar series on COVID-19. I'm Dr. Gary Severance with Henry Schein, and it gives me great pleasure to turn it over to Dr. David Reznik, who's going to give us the latest update on COVID-19 and dentistry.
Thank you, Dr. Severance. As always, it's a pleasure to be with you. I start off with a little bit of troubling news, but for the most part, we're really looking at the good news of what we have to talk about today. Starting off with the not so good news is that we've all heard, if you've turned on the television, that U.S. COVID-19 deaths have now surpassed 500,000. That is 500,000 people have died from the SARS-CoV-2 coronavirus in the United States, and that is troubling. Even more troubling, I'm from the city of Atlanta, and the number of deaths actually is almost what we would consider in the city of Atlanta. So it's equal to our population. And our metro area is much larger, but when you think about a major city being gone due to a disease, I think it puts it in more perspective. And we do know that nothing like this has been around since we had the 1918 influenza pandemic. So we've all had to face something that is new. And I think as dentistry, as our teams, we really have come through in remarkable fashion due to pre-existing infection control measures we had taken after HIV first hit. And then we've had to adjust. We've had to adjust to airborne pathogens, and I think we've done a remarkable job as a field. The other thing that we really need to stress amongst our staff and amongst our family and our friends is to continue to practice public health safety measures when not in the dental facility. We have installed extraoral vacuum systems. I have vaccinations throughout my program. We have air purifying systems, virus killers throughout the program. The air quality in my clinic is fabulous. And most of my staff, about 80% of my staff, has been vaccinated. But we still, while on Grady property, always have to wear a mask. When we are going into stores, we always need to make sure that we have on masks, and we do hand washing. Although it's important to bring up that fomite transmission or touching something, that really is very rare. And so when we first started this series almost a year ago, we talked about removing paper and things from our offices and magazines from our offices because we were afraid of fomite transmission. As long as we do good hand sanitizing practices, which dentistry has done forever, and that I know we do when we're not in the dental office, we're going to be fine. More troubling, though, is we're still on the tail end of this, and we do expect over 90,000 more Americans to pass by June 1st. So it's impacted families. It's impacted some of my patients have passed that have lived with HIV for years, have honestly passed due to COVID. And so it's still serious, and we still need to take in all of those safety measures that we have been using for the last year. If you look at the leading causes of death in the United States, you will see over the last week that COVID-19 was number one. Again, to me, quite troubling, followed by ischemic heart disease, tracheal bronchus, and lung cancer. See how the differences between ischemic heart disease and cancer, lung cancer. We have 16,000 cases in a week of people who died from COVID-19, 10,000, almost 11,000 who died from the second most cause, which was ischemic heart disease. And then you talk about lung cancer and bronchus and tracheal cancer, that's almost 4,000, a significant number down. COPD is there, stroke, Alzheimer's disease, and other dementias, chronic kidney disease, and you can see even diabetes is number 10. What isn't on the list is HIV. And that shows you how remarkable our medicine can be when we give it a chance for the research to move forward, to find targets, and to prepare us, and to get this into a chronic disease. So the advances we've seen with the vaccinations and COVID-19 are remarkable, and I expect we're going to see a remarkable drop in cases as long as we continue to follow those public health measures. If you look at the death rate per 1 million people as of earlier this month, you can see that the death rate is higher in places like Florida And in the Southeast, I mean, we tend to be on the wrong end of death cases and number of cases in many disease states. You can see that California's had their concerns that they've been dealing with. Texas, which now is even facing more of a challenge due to the weather issues that hit that great state. But if you look up in the Northeast, you can see that Maine is doing well, Vermont is doing well, Idaho is doing well over in the Northwest, and we're seeing many more cases where the map colors are changing, that the death rate per 1 million people is beginning to drop, and that is remarkably encouraging news. If you look at the daily reported deaths over a period of time. So when we first started this, when we knew that we had a problem, it barely showed up as far as the number of death cases in March. And then you saw this remarkable, after March 2020, remarkable increase in the death rate. And it's sort of like a roller coaster where it's going up and then it stayed low. In July, we had a little summer bump. Then it was low around until Thanksgiving. And then from the holidays on, we saw this remarkable increase where once again we were setting up, like in Atlanta, the Georgia World Congress Center to take up cases because our hospitals were getting overwhelmed. We saw that happening in different parts of the country. And you can see that January was just devastating and December was devastating. But the incredible news is that number is beginning to go down. But even though it's going down as of February, the middle of February, it is still more than 2,000 daily deaths a day. It's dropped down below that now, and it's continuing to drop. And again, we need to take all those precautions to make sure that we don't lose any of our loved ones. And part of it is going to be how we, as a profession, help our patients, our neighbors, those that we know, get over their fear of vaccination, because that's a great public health measure that we have in place. If you look at the reported daily COVID-19 cases, again, this is from the Institute of Health Metrics and Evaluation out of the University of Washington. You can see what a remarkable decrease we are now seeing in the reported daily cases. But let's look from a historical perspective. It started off low. We were very concerned about what we were seeing. Then in that November, post-Thanksgiving, post-Christmas, post-New Year's, we had this remarkable uptick, and now those cases are truly beginning to drop down, but still at significant levels. And I think that we need to keep that in mind when we're walking outside. If there's no one near us, that's fine to not be masked. But if you go into your grocery stores, you go into any kind of shops or whatever restaurants that might be open, please take those precautions and keep those numbers down. If you look at the estimated percent of the population infected with COVID-19 as of February 16th, again, this is another slide from the Institute for Health Metrics and Evaluation out of the University of Washington. You can see that the percentages, again, are in Maine remarkably low. Very good. But again, if you look in the Southeast, you've got Georgia, Alabama, Mississippi, they're between 20 to 24 cases. If you look at Florida, it's between 15 to 20%. It says better in the mid-Atlantic states. Texas, again, this was before this awful weather outbreak that they had. Their numbers were between 20 and 25%. And then California, between 15 and 19.9%. So you can look at the state that you're in. If you're in North Dakota, they have a high estimated percent of their population that has had COVID. You can look at South Dakota. You can look at the different states in the area and see where you lie. New York, again, one of the states that's been hit hard, still has, they estimate that over 20% of the population has been exposed, which means that 20% of the population hopefully has developed some antibodies. If you look at currently hospitalized patients as of February 22nd, you can see by your state, if you're looking at hospitalizations per 1 million people, how well we're doing. As a country as a whole, it's 171 per 1 million cases. I can tell you, although Georgia's number is high at 265 hospitalizations per 1 million, our numbers are remarkably going down. As a matter of fact, we're getting ready to close the Georgia World Congress Center as our hospitals apparently can manage the load that we have now. But look at New York, 297 per 1 million cases, but nothing is over 500 hospitalizations per 1 million. But Georgia is between that 250 to 500. DC is at 299. Again, just look at your state. Nevada, 195 per 1 million. So we still have a lot of people that are hospitalized from the COVID tracking project, but we can definitely see a great reduction in the number of cases compared to where we were last month and in December. If you look at the total number of tests, it's almost 350 million tests have been performed. We've had about 28 million cases, and as of this date, there were 55,000 that were currently hospitalized. We talked at the beginning about what is the R naught value. What does that mean? It basically is based on combined analysis of death, case reporting, and hospitalizations were available. Current case reflect infections from the 11 to 13 days before I pulled this slide. So it's really for the recent past. But R naught is the infectivity rate. So effective R less than 1 means that transmission should decline, all other things being held the same. So if you look at the map of the United States, we're all beneath 1. So that means one person should infect one other person or less than one person. So what it means is we have a downward trend in the number of cases and transmissibility that we're presently seeing in the United States. This is very, very encouraging news. Not so encouraging news is the proportion of population reporting always wearing a mask when leaving home as of February 16th. There are some areas of the country that are doing remarkably well. Look at Massachusetts. Over 85% of people always wear a mask when they leave their home. Coming to my part of the country, I'll pick Georgia and Florida, it's between 70 and 74% are always wearing a mask. Look out to California and Washington State, and you can see that those numbers are around 80 to 84%. They're doing well. Nevada's doing well. But when we come to our states in the middle of the country, there is room for improvement. And so I think that's important that we keep that in mind. In Nebraska, that number is less than 69%. In Arkansas, again, Oklahoma, that number is less than 69%. Same for Louisiana. So we have areas of improvement where we really need to keep our public health safety measures in place. So what does that mean? The same things I've been talking about since the beginning. Wearing a mask and wearing a tight-fitting mask, and we'll cover that in a little bit. Always washing your hands, and for 20 seconds, that whole happy birthday thing is finally gone, and I'm very grateful. And make sure when you're washing your hands that you cover all surfaces of your hands, not just the palms that we're used to, but by the WHO definition, the World Health Organization. So you do your hands like this, you go on the outside to make sure, you do the finger scrub, and then you get these areas of the palms of your hand. It's really important to wash your hands appropriately and not just to sing happy birthday. A tight-fitting mask, and then maintaining some level of physical distancing, which is truly important. And I think in dental offices always presents a challenge unless you have a really large facility. So we really need to work on helping others wear masks, not calling people out in grocery stores, maybe giving them the eye, but the whole concept is to try to get people to be as safe as possible, to keep them safe and their families safe, our patients safe, our team safe, and those we care about. There's a study that was recently done at the CDC looking for maximizing the fit for cloth and medical procedure masks to improve performance and to reduce transmission of COVID-19 and exposure. This was in an MMWR that was recently published. We know that masking is recommended to slow COVID-19 spread. Cloth masks and medical procedure masks substantially reduce exposure from infected wearers, source control, and reduce exposure for uninfected wearers, wearer exposure. So it really takes two to tango. The people who may have the disease need to be masked. Those trying to protect themselves need to be masked. So the CDC actually did some look and seeing, was double masking better? You might remember Dr. Fauci on one of the morning shows says, well, 2 would be better than 1. And then there was some step back, and then there really wasn't research backing it up. So the CDC actually did do the research. They conducted experiments to assess 2 ways of improving the fit of medical procedures: fitting a cloth mask over a medical procedure mask and knotting the ear loops of a medical procedure mask and then tucking in and flattening the extra material that's close to the face. Again, it has to have a tight fit. That's why when we're looking at our N95s, we get fit tested to make sure we have a good tight fit. Do I worry about how our practices in our dental practice? No. By now, we should be wearing N95s. We should be fit tested for our N95s. We should have on face shields or eye protection, disposable gowns, and using all the tools that we have if we're performing aerosol generating procedures. So the experiments actually showed the importance of a good fit of the mask, and I think that is something that's important. As good as some of our tools are, we know that high volume evacuation in a dental clinic is going to reduce about 90% of the aerosol and splatter. But that's still 10% that's out there. So that's why I take the extra steps of using the extraoral aerosol evacuation system. And I also want to filter the air. I think it keeps my staff healthy, it keeps my patients healthy, and it's taking every precaution that I can to ensure the safest dental visit. This mask really gives you the idea. So in lab tests with dummies, exposure to potentially infectious aerosols decreased about 95% when they both wore tightly fitted masks. So the first picture on my left is a cloth mask over a medical procedure mask. That's fine. So you put in my case, it would probably be a Tampa Bay Buccaneer mask over my mask or some other kind of cloth mask when I'm out in public. But something that we're doing inside the clinic is with our medical procedure masks, not our respirators, but our medical procedure mask for non-aerosol producing procedures. It's to knot it near the ear loop and then tuck it in on the sides. And this gets you a nice tight fit. We have people that twist their ear loops, twist the little things, the connectors, and what ends up happening is you create pockets where literally aerosol and air can get in. So having the knotted area towards the base of the mask and then tucking that in, the extra material in, gives you that nice solid fit. Other effective items that they showed was a mask filter, although getting the filter seems to be a bit challenging right now, and then a nylon covering over the mask. And we see a lot of those. If you're a football fan, you saw a lot of those on the sidelines. If you're basketball, you see people wearing those as well, or just see them in normal daily life. Again, the key is a tight fitting mask and making sure that you have at least an extra layer if you're just wearing a surgical procedure mask. The next figure I'm showing is the estimated proportion of adults in the population that is open to receiving a COVID-19 vaccine. This was actually based on a Facebook survey response, and the 2 things were yes and unsure. And to me, this is a bit problematic because if you look at the Southeast, if you look at Kentucky, you look at some of those states, they're only 60 to 69% of people would actually want to get that vaccine. And how do we protect ourselves from the flu? We get the vaccine. How do we protect ourselves from shingles? We get a vaccine. One of the things that I'm very passionate about for young people, and now it's up to age 45, is getting vaccinated for human papillomavirus, the number 1 sexually transmitted virus that we have today. And it does cause issues with oral warts, oral cancers, and things of that sort. So getting vaccinated is something that will prevent cancer is important and something that we're doing. Getting vaccinated against meningitis, something that's important that we're doing. Getting childhood vaccinations against measles, mumps, and rubella, important, something that we're doing. And right now we're in the midst of a pandemic, the kind of pandemic we have not seen in a century. So getting vaccinated to protect yourselves and your loved ones is how we really need to move forward. And what we need to do is to be able to talk to our patients, talk to our neighbors and really address some of the concerns they might have. So the more information you have about potential side effects of the vaccines, the more information you may have about the safety of the vaccine will make it easier for you to talk with your patients, to talk with family, to talk with friends, and to help them get vaccinated so we can return to some level of normalcy. If you look at Texas, again, between 70 and 74, Nevada, between 70 and 74, a higher percentage in Massachusetts, again, higher percentage in California. I worry about what some people refer to as flyover states, but those are states that I've done a great deal of work, and there are wonderful people in each and every one of these states, from Oklahoma to Kansas and Missouri and the Dakotas and Colorado and areas like that aren't on the coast. These are the heartland of America, and we really need to do what we can to take away the fear of vaccines and help people get vaccinated. So there has been safety monitoring over the COVID-19 vaccine. We do watch that. There are different kinds of reporting systems. The CDC has one. And this again was published in the CDC's MMWR, the Morbidity Mortality Weekly Report. This was in February 19th. And what we're talking about are the vaccines that have been approved at this point. It should be this week that J&J's vaccine, the single-dose vaccine, will be approved, and we'll get more data on that. Right now, I believe the initial things was it was about 66% effective against severe illness and 100% effective against hospitalization. So I think those are information that will come out from the FDA that we will see this week. But what do we know? We have 2 authorized vaccines in the United States. They're under emergency use authorization. In pre-authorization clinical trials, local and systemic reactions were reported. No serious safety problems were detected during the controlled clinical trials. But we do monitor outcomes, and it's part of the U.S. vaccination program. So it's not like we're sticking people and there's no way to report what's happening. There is the VAERS system that actually allows us to report any kind of unusual effect that people are having. And what it indicates is reassuring safety profiles of the 2 vaccines that are now available within the country. Local and systemic reactions are common. There is going to be some kind of reaction, but with very rare reports of anaphylaxis. I have a very dear friend who is allergic to many things, including very allergic to the hepatitis B vaccine, and had an anaphylactic response. This individual did not have an anaphylactic response. But that's why when you get the vaccine, they make you wait 15 or so minutes to see. That's why when you get the vaccine, some people are recommending that you take the next day off just on your second dose to make sure that you don't have any untoward effects. And we're going to go over what some of these are. But counseling vaccine recipients and being honest with them to expect some transient local or systemic reactions might ease concerns. So it's not that you're going to say, oh, I got it, nothing happened. I think we need to be honest with people, as we always are. We're healthcare providers. People trust us. They trust us with their oral health, which we know you can't be healthy without oral health. And there's so many other messages that we do. We do nutrition counseling. We do smoking cessation. We talk about substance use. There's so many different things that we do. And now that we're in more medical dental integrated model that we're working towards, we can help our patients. And many of us are actually able to give vaccines now. A dear friend of mine who is the chief dental officer in Illinois, I saw on Facebook that she was giving vaccine. So it's really important that we take responsibility to educate, to help get some of those areas that were below 75% up to 75% so we can try to get herd immunity. So the first month of the COVID-19 vaccine safety monitoring report, which was between December 14th, 2020 and January 13th, 2021, published in the MMWR in February 19, shows you on the first day what people were talking about would be injection site pain. I, for one, did not have that after the first shot. Other people, a small percentage, less than 10% after the first shot, talked about fatigue, talked about, this is on the day of, talked about a headache, very less than 5% had myalgias or muscle pains, and a small percentage had chills. If you go to the next day, which is when we normally see it, day 1 after the vaccination, you see a great deal of people talked about injection site pain. And so for me, what was that injection site pain? I really didn't notice it until I rolled over in the middle of the night and onto my shoulder, and I thought, whoa. So I did feel it. So I would be one of those that's close to 80% that did have injection site pain. Then you can see that fatigue was around 25%, headache went to about 20%, myalgias were more reduced, and then chills were reduced. And as you can see, according to the chart, the further away you got from that first day, you saw a remarkable drop in these transient effects of the vaccine. So what about the second dose? What about day 2? The second dose has been reported to have more significant impact. So on the first day, 40% of the day of the shot, 40% said they had injection site pain. It was over 10% had fatigue. There were some reports about 10% having headache, myalgia, etc. And then if you look at day 1, this is after the second dose, you can see that injection site pain went up to about 80%. Fatigue was closer to 50%. Headache was closer to 42%. Myalgias, muscle pains, fevers, and things like that sort were over 45%. And a significant number of people had chills. But if you watch the trail, this is transient. What this means is your body is forming an immune response. It's an inflammatory response letting you know that your body is working. The pain will be temporary. It won't last a great deal of time, but that you need to be honest with people. What I've noticed with my residents, after the first day after their second dose, they were hit. They had exhaustion. They had really the number one thing I heard was fatigue. I did have one of my residents who had the myalgias. I had one that had fever. On my older staff, regretfully, in a good way, at this point, we really haven't seen those same kind of symptoms more than fatigue and a little injection site pain. But you need to be honest with people. If you're going to get this injection, you're going to get a reaction. And what that reaction means is that your body is working. Antibodies are forming. Your T cell response is forming. So this is actually an important component of what's happening. Yes, it's uncomfortable, which is why we recommend if you can get your second dose on a Friday, take the day off. Or, if you can get your second dose on a day that the clinic is not open, your office is not open, then go for it, because you will have some fatigue. There's a good chance you're going to have injection site a reaction, which is why I had my injection done. I'm right-handed, so I had it done on my left arm, so I would be able to function the next day. So these are just things of being honest with our patients and where we are. And this is with the Pfizer BioNTech COVID-19 vaccine. So we have days for the first injection, and we also have information on the second injection. And the number of people that were included in this trial were almost 750,000 on the Pfizer dose 1 and 235,000 on Pfizer BioNTech dose 2. If we look on to our other one, the Moderna vaccine, I only really have the data here for the first dose. And what it shows on 0 day, that there was some injection site pain, some fatigue, some headache, but not much. Again, it's the first day after. Injection site pain was the number one thing that was reported, followed by fatigue, headache, and myalgia. Again, you can see these numbers basically trail off. Again, it just means that your body is reacting to the vaccine. So there is another source, and I think it's going to be an excellent source, of the American Dental Association having a webinar to prepare us and our teams to discuss these COVID-19 vaccines. So I gave you some information. I'm sure the ADA is going to give us more information, but it's a free webinar that is scheduled in March, early March. If you're seeing this broadcast later, I'm sure the American Dental Association will have it online, but it really helps us educate, gives us more information, additional information on how to educate our patients about COVID-19. The webinar will also cover tools for addressing patient concerns, which we're seeing. I still have some staff members that have not been vaccinated, separating facts from misinformation, and remaining sensitive to racial and cultural concerns that may contribute to vaccine hesitancy. We can never forget about certain things that impact certain communities. The Tuskegee incident with syphilis has really had an impact on our minority communities, and that's for a reason. And so we do have health equity issues in our country, and we want to make sure that everyone, no matter your resource, no matter your level of income, no matter if you were born here or immigrated here or whatever the case is, that we want to get herd immunity. We want to get everyone as possible vaccinated. So dentistry can play a huge role in that. Switching to how fast is this virus mutating? And this is from the American Society for Microbiology. It's a wonderful organization I did work with when I was looking at candidiasis in people with HIV. A typical SARS-CoV-2 virus accumulates 1 to 2 single nucleotide mutations in its genome per month. So that is half the rate of the flu and 1/4 the rate of HIV. The issue that we had with HIV early on was that it would mutate, and it would mutate away from the drugs. So one of our first trials that we ever did was with a medication called AZT. And what we saw was that people did well at the beginning, and then all of a sudden that they sort of crashed. And there was no benefit in extending your period of life if you were on that medication. And what we found in those days was that HIV was mutating around the meds, which is why we use combination therapy now, which is why we have medications that can prevent sexual transmission, which is why if you know someone that's HIV and they have undetectable viral load, they cannot sexually transmit the virus. So we've been able to overcome the mutations for HIV. This virus doesn't mutate nearly as much as HIV. This virus doesn't nearly mutate the rate of the flu. So why is this? Well, part of the reason is that COVID-19 appears to be mutating more slowly is that unlike most RNA viruses, coronaviruses have a novel exoribonuclease encoded in their genomes, which researchers suspect is correcting many of the errors. So this is like a fix-it tool that these cells have occurring during replication. So you won't, if you're getting rid of the bad mutants and you're keeping on, that's why you're not seeing as many different kinds of mutations. Genetic inactivation of this exonuclease in SARS-CoV-2 and murine coronavirus increased mutation rates by 15 to 20-fold. So if you didn't have this exoribonuclease, which this virus does, you would see greater replication, you would see greater mutation. So it literally has something within it, which is sort of a way to stop the mutations, and that's important. The molecular basis of COVID or coronavirus proofreading is complex, and it's being investigated as a possible therapeutic agent. So can we use this knowledge that we have to help treat? And that's what you're seeing why the death rate is beginning to drop is not only do we have less people getting the virus now, less people hospitalized, but we have better treatments once you do get the virus. So it's still making progress. There is a reported new worrisome variant that's coming out of California. You might have heard on the news. It was first identified in Denmark, and it's now surging through parts of California. And it does represent more than half of the samples in 44 counties, according to new data out of University of California at San Francisco, or UCSF. Additionally, people who are vaccinated seem to produce fewer protective antibodies in response to this variant. So this variant could potentially escape or evade our immune defenses. But compared to the original virus, the L452R variant is somewhat more aggressive with an elevated secondary attack rate of 35%, up from 25%. So that means it could spread more quickly in a home, it could spread more quickly in a community, it could spread more quickly in a bar or restaurant that is not following social distancing and masking requirements. The research team found that the variant represented 53% of all positive test samples collected at the 24th Street Mission BART, which is a rapid rail station in San Francisco in a predominantly Latinx community, and they looked at this between January 10th and January 27th. There was a significant increase from November when it comprised only 16% of the positive tests. Now it's 53%. So you can see it's multiplying and it's becoming the more dominant variant in this particular part of California. California's new variant seems less ominous or scary than the other variants that we're aware of. The B.1.1.7 variant, which was first described in the UK, the B.1.351 variant, which was first described in South Africa, and the P.1 and now P.2 variants, which were first described in Brazil. Good news is that the FDA has outlined a fast path for new vaccines, booster shots to cover the new virus variants. We know how the technology works now. It's just like how we changed the flu vaccine based on what we think we're going to see. Here we know what we're seeing. So we need to be able to address these variants to make sure we stay protected. So drug makers will not have to perform massive trials, which could take quite a long period of time, for new booster shots developed to combat worrisome new variants of the coronavirus. And this was released this past week. The FDA said that immunizations that protect against the variants could receive clearance based on so-called immunogenicity studies, where researchers vaccinate people and then conduct laboratory tests to measure the strength of their immune response. So we already know what side effects the vaccines are going to have. When we develop these new vaccine boosters to address the variants, if need be, we're really going to look and see what happened with people on their phase 1 trials and phase 2 trials. The acting FDA Commissioner, Janet Woodcock, stated, by issuing these guidances, we want American public to know that we're using every tool in the toolbox to fight this pandemic. And we need every tool in the toolbox to fight this pandemic, including changing as the virus adapts. We need to adapt to the changes. The virus is going to adapt to changes, so we need to stay on top of it. The acting director of the FDA said drug makers should not wait until a mutated virus is demonstrated to be able to escape the vaccines to begin developing new versions. In other words, we need to stay one step ahead. We start developing something. We see what happened in the UK with that first variant that was there. The B.1.1.7 variant, we know that became the predominant variant in the UK. We don't want it to become the predominant variant and then try to put in the booster. So that's good news as far as how we're going to address the variants, and will we need to have an annual booster? Those kinds of information is still something that's being researched, but quite possible. So what is a long hauler? Have we heard people that are COVID-19 long haulers, or they have long COVID, or they keep on having symptoms post having the disease and no longer being infectious? Persons with long COVID often present reporting persistent severe fatigue, headaches, and brain fog, which is defined as mild subjective cognitive impairment approximately 4 weeks after acute illness. And after acute illness and 4 weeks, at that point, there should be no replicating virus. A study recently published in The Lancet found that of 1,700 or so coronavirus patients treated in Wuhan, China, 76% were still experiencing at least one symptom 6 months after the symptoms began. The key: wear your masks. Get vaccinated. Don't get coronavirus, because we really are still looking to see what these long-term symptoms are and how they're impacting our pulmonary system, our cardiovascular system, and will there be any kind of long-term consequence. Remember, this virus is a year or so old, so we're still learning as we move forward. Doctors have reported that the severity of COVID-19 illness may have little impact. In other words, you can have mild disease and still have long COVID symptoms. You don't have to have severe disease to have long COVID symptoms. Just a little more than a year ago into the pandemic, we're not clear on how many COVID-19 patients will go on to develop what's called long-term COVID. So again, it's a new disease. It's something that we're looking at. It's something that we're learning things about every day. A recent study that included mostly people who had just mild cases found that 30% were reporting symptoms as long as 9 months after contracting the virus. Other studies have found a higher percent. Again, anything we can do to prevent our patients, our families, our staff from getting this virus is definitely warranted. So long-haul COVID clinics are springing up around the country to actually address this. We have one at our hospital. There's clinics in California that are set up. I'm sure they're set up throughout the entire country. There are more than 100 symptoms that people are reporting. The number, if you look at it basically in the order that they're performed, the percentage, fatigue is number one, followed by headaches, brain fog or memory loss, GI concerns, muscle aches and pains, heart palpitation, even some have developed diabetes. So we really need, again, to do what we can to prevent, and then realize that some of our patients who have had COVID in the past still might have symptoms. What do people think? 14% of parents don't think it's safe to go to the dentist. And I think that we're one of the safest environments to actually go to. But we have to communicate that to our patients. We have to communicate that through all members of our staff and all kinds of different kinds of communication. Remember, we focused on how we communicate with our patients early in the epidemic when they realized that the dental team was at risk because we were in the oral nasopharyngeal area. But we did things to address that. So there was a survey, was published by Teresa Pablos from bicuspid.com. There was a survey conducted by C.S. Mott's Children's Hospital at Michigan Medicine in January to get a better sense of how the pandemic is impacting oral health. The findings highlight the importance that dental professionals sending appointment reminders and telling patients about changes that we have put in place to make our practices safer during the pandemic. And so again, communication is key. The National Poll on Children's Health asked parents of children ages 3 to 18 years about their oral health care experiences during this pandemic. About 2/3 of parents felt it was safe for their child to get preventive care right now. In contrast, 19% felt they were unsure, and 14% felt it was unsafe. So we still have 33% of the population who are not sure whether they can take their kids to the dentist. And we have got to protect our children's oral health. That's where we start with getting people on the right path to maintaining oral health, because you can't be healthy without oral health. A total of 40% of respondents had not tried to get preventive care for their children since the pandemic started. This pandemic has been a year or more. Out of these parents, 40% did not want to risk exposing their child to COVID-19. That's understandable. No one wants their child to get sick. 28% said they didn't make an appointment because their child was not having a dental problem. Again, prevention, an ounce of prevention prevents these dental problems from occurring. The 60% of parents who tried to make a preventive dental appointment, getting care was not always easy. 1/3 of all parents said COVID-19 had made it harder for their child to get preventive care, and 24% of parents experienced a delay when making an appointment. That was possibly due to how we were spacing out patients earlier in the epidemic. At this point, my program is up to full snuff. We're where we were before the pandemic. But what's really troubling, 7% of parents said they tried to get a preventive dental care for their child but weren't able to. And we really need to address that as a country. This occurred more frequently among parents with Medicaid, about 15%, than private dental insurance, 4%, or no insurance, 5%. So again, we know who has Medicaid. We can target people with positive messaging. I know the Ad Council had that brush your teeth for 2 minutes twice a day and floss once a day, trying to do a simple 2-2-1. We really need to do what we can to ensure that our children and our adults and our geriatric patients, that everyone who needs oral health is able to access it. That has been one of the goals of my career. Good news. Keeping kids' teeth healthy during COVID-19, the percent of parents reporting improvements in child's oral health habits. I think this is fabulous news. Brushing more often, 16%. Good to hear. Flossing more often, 11%. Fabulous to hear. Using fluoride rinses more often, 9%. Drinking sugary beverages less often at 15%. So the sugary beverages we know has been an issue since the beginning. Excellent news. The fact there was an increase in flossing is always good news, and the fact that children are brushing more is excellent news. But we still need our patients to come and see us so we can do that preventive care to ensure they don't have problems and don't lose teeth. I can tell you in my program, which predominantly treats adults, my number one expense is replacing missing teeth. We have to start at a young age to get oral health and preventive measures across and make sure they stay throughout the person's lifetime. As always, it's been an honor and privilege to spend time with you. I'm looking forward to answering your questions on Friday as I normally do. And back to you, Dr. Severance.
Thank you very much, Dr. Reznik, for that update. If you have any questions, concerns, or suggestions for future topics, please email us at webinars@henryschein.com. Also, please subscribe to our YouTube page by clicking the button below. I'm Dr. Gary Severance with Henry Schein, and as always, until next time, stay safe and stay informed.